It's very loud.
But I stumble and I falter every day.
You don't have it.
But I love my baby now. But I love my baby, I'm still learning how.
Yep, these are all the questions.
Hey, 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 I'm okay.
Hello, and welcome to Pathways to Parenting Success. I'm Jan Hittleman, the Director of Boulder Psychological Services, and it's my pleasure to welcome you here for our panel on ADHD, Challenges, Diagnosis, and Treatment. Since I have the opportunity to be on the panel today, it is my great pleasure to introduce our moderator, Leisha Connors-Bauer. Leisha is the manager of the Boulder County Healthy Youth Alliance and a BVSD parent. I've had the pleasure of working with Leisha on so many projects over the years. She's a fantastic community servant. We're really lucky to have her here. And it is my pleasure to introduce Leisha Connors-Bauer.
Thank you, Jan. So a few reminders I'd like to share with our audience here and our audience at home. So we're encouraging people to submit questions for the panelists. Home viewers can submit questions by going to boulderpsychologicalservices.com and clicking on the link to the home page. So please remember to get on that computer at home, or if you're in our live audience, to fill out an index card with your question and participate in the discussion tonight. So tonight we have 4 panelists joining us. And in a minute, before I introduce the panelists, I'd like to go ahead and remind everybody that this weekend there will be an all-day conference on ADHD entitled Late, Lost, and Unprepared on Saturday, November 6th from 9 a.m. to 4 p.m. here at the BVSD Ed Center. If you're interested in learning more, contact the parent liaison, Anna Stewart, for more information on the conference, or the BVSD ADHD Parent Support Group, which meets monthly. Contact Anna Stewart at anna.stewart@bvsd.org or call her at 720-561-5918. So tonight we are joined on the panel by Dr. Lee Johnston. Dr. Johnson will be discussing the history and diagnosis of ADHD. He will be followed by Dr. Jan Hittleman, who will talk about other conditions that may be confused for ADHD and how to do a thorough assessment. Elizabeth Matthews will talk about social and relationship issues as relates to ADHD. And Dr. Wyatt Fisher will close the presentations from our panelists on effective parenting strategies with ADHD children. Each panelist has approximately 10 minutes to share information with you on their topic, and following their presentations, we will open it up for questions from the audience. Dr. Leland Johnson is a psychiatrist and psychoanalyst for children, adolescents, and families. He has been in private practice since 1983, first in Seattle for 17 years, and now in Boulder for the last 10 years. He teaches at the Denver Institute for Psychoanalysis and is clinical faculty at the Department of Psychiatry, University of Colorado Health Sciences in Denver. Dr. Johnston.
Thank you, Alicia. The setting of this series of talks is Pathways to Parenting Success. And I've heard it say that it takes a PhD to parent this disorder, attention deficit disorder. I'm going to try to give a little bit of background clinically before passing it on. It is a neurobiological disorder, neurobehavioral disorder. That is not very well understood in the community at large. It has always been controversial, primarily because stimulants have been so instrumental in some of the treatment measures. I'm going to give you a bit of the history just to kind of understand how it's evolved as a diagnostic entity. First, it was discovered on a brain trauma unit. I mean brain trauma that's organic. Accidents, falling, kids that have had actual brain damage. That inadvertently, if you gave a stimulant to these kids who were bouncing off the walls with a hyperactivity or could not attend, stimulants would settle them down in a paradoxical fashion. This got a lot of attention because it was it could be reduplicated wherever it was seen. So there began to be the effort of trying to set up the syndrome that could be researched prospectively in time. Syndrome meaning a collection of symptoms. And the attempt was to try to collect those symptoms in kids that were seen without organic brain injury. So the term was minimal brain dysfunction. and the data was there. Stimulants would help these kids. So the effort that is currently used for labeling the symptoms that we try to research, the latest iteration of that is from 1994, the DSM-4. I'm going to briefly go through those diagnostic criteria. They're very simple to try to help you understand how we've gotten to the place we are now. This is now 2010, and that's how many years? 16 years since anything has changed about the diagnostic criteria. But a lot has been discovered since then. But the list of symptoms really are categorized according to three different parameters. They either fall into inattention or hyperactivity or impulsivity. And the symptoms have to begin before age 7, and they have to exhibit a certain degree of dysfunction in children, either at school, home, or socially. And if you have those criteria and you have an exclusion of anything else that causes those symptoms, then you've simply got ADHD. Now, the Adhd label is divided into three categories. You either have primarily inattentive or primarily hyperactive / impulsive, or you have combined, both. Now, a lot has happened. I think the biggest developments have really been in regards to functional magnetic resonance imagery and neuropsych testing, including many parameters of psychological testing. And in the years that we've been studying this, we now understand that the disorder emanates from the prefrontal cortex. It has nothing to do with intelligence. It has all to do with how things are executed. So the term executive function now is much more current rather than trying to track things in terms of the syndrome of symptoms called ADHD. Still use that syndrome of symptoms, it's very pertinent in terms of trying to delineate the disorder. But executive function is a much more comprehensive label. To describe it briefly, executive function is when the brain takes in perceptually all that's going on externally, internally, weaves it through the synapses into working memory. Working memory is not conscious memory. It's not short-term memory. It's a very unconscious process. And then things are executed out of working memory in order to accomplish things like focus, organization, prioritization, multitasking, modulation of impulsivity, modulation of activity levels, modulation of emotion. All of that is executive function. And you can imagine how complex that area of the brain is to just simply execute. There are many, many things that can interfere with executive function. I'm going to make a quick list, and Jan will be talking more about this, but trauma in particular, obviously organic brain trauma, but psychological trauma can cause executive function issues. The list goes down through anxiety, mood disorder, and many medical conditions. For example, metabolic conditions, endocrine conditions, seizures, and not necessarily always absent seizures, but anything that will spike the prefrontal lobe. It can involve genetic disorders. It can involve neonatal injury. And, of course, medications can cause executive function issues. This is to say that if you exclude all of those things, you can still use the label ADHD. It's a diagnosis of exclusion. Now, the most central aspect of trying to diagnose really involves the clinical interview. And the clinical interview involves history taking, not only from the patient, from many sources of information. 2 out of 3 cases of attention deficit disorder will have comorbidities. Comorbidities meaning dysfunction that exists in other spheres besides executive function. For example, learning disorders. OCD, that's obsessive compulsive disorder. Oppositional defiant disorder. TIC, mood disorders, anxiety. I'm going to have Jan pick it up from here and speak more specifically about testing and delineating some of the comorbid features.
Thank you, Lee.
Okay, our next panelist, Dr. Jan Hittleman, is a licensed psychologist with over 20 years of experience working with children and families. He also authors a monthly column for the Daily Camera and for the Boulder Valley School District under the sponsorship of the Parent Engagement Network, and he writes online for Rosen Publishing Group. Jan is the founder of the Boulder Counseling Cooperative and is currently director of Boulder Psychological Services.
Thank you, Leisha. We use the term comorbidity to indicate that there is more than one diagnostic issue going on. And comorbidity is the rule, not the exception, oftentimes with the ADHD diagnosis. In fact, 58 to 87% of children diagnosed with ADHD have at least one comorbid disorder. Up to 20% may actually have 3 or more disorders. The most common comorbid conditions include oppositional defiant disorder, and we see this in over half of children diagnosed with attention deficit. And we also see a comorbid occurrence of learning disabilities or language disorders. We see this in 25 to 35% of children diagnosed with ADHD, as well as anxiety disorder, which we see up to 30%. And about a third of the children diagnosed with ADHD also have a co-occurring mood disorder. So it's very important to be thoughtful in terms of our diagnosis. In fact, there's a long list of issues that are often misdiagnosed as ADHD, including things like depression, anxiety, learning disabilities, giftedness. We had gotten a response from a parent recently about this issue. It's a very common challenge for parents of gifted and talented children where they are misdiagnosed as having ADHD. There could also be hearing problems or language problems, which can impact the kind of symptoms that we see with an ADHD diagnosis, as well as post-traumatic stress disorder, head injury, as Dr. Johnston mentioned earlier, even physical or sexual abuse, and certainly neurological disease as well. And so it's very important to be thoughtful about the diagnosis. This evening, I brought a few real case studies to briefly go over with you to give you a sense as to how through psychological assessment we can differentiate children who appear to be ADHD but in fact have other things going on that need to be addressed. And I will be at the conference, the BVSD conference, this Saturday, and there I'll be providing a lot more information about case studies, providing more information about the specific psychological tests that we use, etc. So hopefully you'll join us there as well. The first case study that I'd like to share with you was an 11-year-old boy that I will call Nate. Nate was a 5th grader. He had a history of depression, anxiety, a disorder called trichotillomania, which is hair pulling, interpersonal challenges, and also oppositional defiant behavior. His aggressive and destructive behavior at home escalated to the point that he was hospitalized in September of 2008, and then in December of 2008, he was placed at a residential treatment facility for boys. Placement reports indicated that his hair pulling resolved shortly after he was admitted to his placement. And current testing was requested to provide an update in terms of his overall intellectual achievement, emotional functioning, but also there were concerns for many, many years about whether or not he had attention deficit disorder. And it's understandable that people would have these concerns because he did at times exhibit many of the symptoms that are part of the criteria, as Dr. Johnston went over earlier, for ADHD. In fact, if we just looked at the symptom checklist, he would have qualified for the diagnosis of ADHD. I'm just going to give a very brief explanation of some of the tests that we use, and then I will be able to do this in more detail for our conference on Saturday. One of the tests that's often given in a psychological battery is the Wechsler Intelligence Scale for children. It's an intelligence battery. Many people are interested in the IQ score, but in a sense, that's the least important information. What's really important is to look at the different subtest scores that make up the overall IQ score. And when Nate was administered the WISC, which is what we call it for short, the WISC-4, which is the current edition, the testing really showed a lot of strengths in most areas. Verbal comprehension subtests were all strong. They ranged between the 50th and 91st percentiles. Perceptual reasoning, which is nonverbal, skills and abilities, also very strong, between the 50th and 98th percentile. The area that we usually see issues with ADHD children are in two of the composites, the working memory subtests, which requires a lot of attention and concentration because memory is required on all the tasks, as well as a series of tests that are called processing speed subtests, which require the child to complete a task within a certain limited period of time. Kids with attention concentration problems often show deficits in these two areas. And with this young boy, Nate, he actually did great on the working memory subtest, which is usually where we see an issue. He was between the 50th and the 84th percentile. And on the processing speed subtest, he did pretty well there too, between the 25th and the 63rd percentile. And this is a boy with an overall IQ score of 112, which is at the 79th percentile compared to other children his age. He was also administered the Test of Variables of Attention, or TOVA for short. And this is a test that was specifically developed to look at attentional skills. However, even the developers of this test caution that we should not base the diagnosis on any one measure, even the TOVA itself. And when he was given the TOVA, his response was very interesting. He was working on the test diligently. The TOVA, by admission of the gentleman who developed the test, is the most boring test that you can imagine, and it requires incredible attention to do well. And what we noticed with this young man is he did very well for the first half of the test, and then the second half, he just started responding randomly. And it was clear from his test profile that he wasn't really missing the targets, he was just pushing the button, responding randomly, which invalidated the test. So that tells us that he really had an attitude about taking the test more than an attention problem while he was completing it. There's also a subtest on the Wechsler Intelligent Achievement Test, which is a test that looks at academic skills that he was administered. And one of the subtests, called sentence repetition, is just like what it sounds. You give sentences to the child and they have to repeat them. They become more and more difficult. On this test, he did fine as well. He was at the 55th percentile, which also discounts an ADHD diagnosis. Finally, he was given the BASC, which is a behavioral assessment for children. It's a survey that the parent fills out, that the child fills out, and a teacher can fill out as well. And on that, on his self-administered BASC, he indicated significance around a negative attitude towards school and towards teachers, but nothing about attention issues from his subjective experience. His parents, however, saw a lot of issues that related to attention. They also saw issues related to aggression, anxiety, and a number of other things. The teacher, which was very significant as well, did not indicate any attention issues either, but noted anxiety and conduct problems. And so it turned out, in this case, even though it was understandable that people might think that he had an attention problem by the way that he presented, when we looked carefully at his prior assessments, history, and current test data, it indicated that his attentional issues were a function of behavioral and emotional factors. There was also personality testing that was given. And so it became clear that his exhibiting attention and concentration problems was emotionally based, not based on attention deficit disorder. And so he was treated for anxiety, dysthymia, which is a form of depression, and oppositional defiant disorder. Another example is a girl that we'll call Kathy, who was 8 years old when she was assessed in second grade. And Kathy was a very interesting case. She was recently retained in second grade because she was having tremendous problems learning in school. And through careful and thorough testing, it turned out that her issue, in addition to attention issues, related to visual sequencing problems. And visual sequencing is a key processing skill in terms of reading, math, and learning. And so while she did indicate through the testing that she had ADHD, because her subtest scores on the working memory subtests as well as the processing speed subtests were all very low in a consistent fashion, we also saw through additional testing that when she was presented with visual information, she had tremendous problems with sequencing and processing that information as compared to auditory information where she did much better. The other thing that was a little bit of a giveaway with Kathy is that she had a lot of trouble staying seated during the testing. She would fall out of her chair frequently, be distracted frequently, so there were observable signs of impulsivity and hyperactivity as well. She also took the TOVA, and what was very interesting in terms of her Tova Assessment is there was a section where she did something that's very unusual. There was a series of targets that she was supposed to push the button indicating that she saw those targets, and she missed many of them in a row. And I could see that she just kind of was looking away. And I went over her Tova testing with the gentleman who created the Tova, and it indicated the possibility of a seizure or sleep disorder based on her responses. And so again, even though it was clear that she had ADHD, more of the impulsive hyperactive type, there were so many other issues that were so important that we were able to discover her visual sequencing problems, as well as the rule out for a possible neurological disorder. And so she was referred to a neurologist, and we're waiting for the results of those tests. Finally, when I went over the testing with her parents, they said, well, you know, our son seems to have concentration problems as well. Maybe we should take a look at him too. And I had the pleasure of testing Tom, who was a 10-year-old in 5th grade. And Tom was a very friendly child of average to high average intelligence, and his academic skills were also in the average to above average range, which also discounts somewhat ADHD, because if you have serious ADHD, it's very tough to be at or above grade level in all of your different academic areas. And Tom was also given similar testing, and he was strong in the areas of the working memory subtests, as well as the processing speed subtests. He also passed the Tova, which is a very tough test to pass unless you have good attention skills. On the sentence repetition subtest that I referred to earlier, he was at the 91st percentile. Even though his parents and himself, as well as his teacher, indicated attention problems on the BASC, it turned out that Tom loved video games and movies, and he spent a lot of his time thinking about video games and movies, and not necessarily what was going on in the classroom. And so he was, I don't think there's a diagnosis like this in the DSM, but he was a space cadet, which is different than ADHD. And with the right motivational strategies, we're hoping that Tom can turn things around in terms of his functioning. I have a few more, but I'm going to pass the baton on to the next presenter.
Before we move on to the next presenter, I would like to remind the live audience to submit your questions for our panelists, and to remind our home viewers to submit your questions to boulderpsychologicalservices.com by clicking on the home page, and they'll pop right up right here so we can get to your questions as soon as they're here. So our next presenter is Elizabeth Matthews, who'll be talking on social and relationship issues as that relates to ADHD. Elizabeth is a local licensed psychotherapist and member of Boulder Psychological Services. She has worked with adults, teens, and families in the Boulder area since 1996. Founder of Thumbs Up, Elizabeth's current work focuses on building relationship skills with groups, families, and individuals.
Thank you, Leisha. Thank you for being here today. I'm going to speak on peer relationships. Now, the symptoms of ADHD, inattention, impulsivity, and hyperactivity, often interfere with a child's ability to correctly interpret social cues. So social interactions for these kids sometimes can be clumsy, awkward, and feel a bit off. They're not quite comfortable. While it's commonly accepted that symptoms of ADHD make it difficult to learn in school, what's less discussed is how these same characteristics, such as difficulty following instructions, staying on task, and deciphering information, may also interfere with the ability to learn social and communication skills. So when a child goes to school, the benefit in school of learning academics is that the academic information is presented, reinforced, and practiced, whereas social and relational skills are very rarely presented in an easy-to-follow manner, reinforced and practiced. The good news is that social skills can be taught, and with practice, competence can be achieved. Social skills, like any other subject, sport, or art, can be learned and practiced. Healthy self-esteem is enhanced by supportive friendships. Learning relationship skills is important to feeling comfortable in your own skin and to feeling good about yourself. If relationships aren't fun, comfortable, and rewarding, relationships can be something that people want to avoid or control. So now let's go back to the ADHD symptoms. How does inattentiveness affect peer relationships? Children who have difficulty paying attention may miss social cues. This makes it difficult to read their peers and to understand the messages and responses they are receiving. In play, inattentive kids sometimes forget rules of the game, which frustrates their peers, and it may make their peers think that this is an immature kid and someone that they don't really want to play with. Ironically, inattentive kids sometimes become so hyper-focused on reading or playing a game that they ignore their peers and seem to be unfriendly. Because of these frustrations and these social awkwardness, inattentive kids may find it safer or more comfortable to isolate themselves and to stay on the social periphery. They're more likely to be neglected by their peers and not sought out for social activities. Now, the consequences of hyperactive and impulsive behaviors. Hyperactivity, impulsivity can result in a disregard for physical boundaries, a tendency to interrupt others, a tendency to speak loudly and sometimes very quickly. Inattentive, hyperactive, and impulsive kids sometimes seem to overreact to situations that other people may stay calm at. They may seem easily angered, be aggressive, and dominate play. These kids, too, find it difficult to read social cues, and they can also be intimidating. So these characteristics may lead to rejection. So there's some evidence that this social quagmire of inattentiveness, impulsivity, and hyperactivity increase the likelihood that these children will be involved in bullying incidences. If bullying occurs, the inattentive child, the child who's more shy, tends to be the victim. And if a child is hyperactive, who seems to be maybe more aggressive and more impulsive, they might be the victim or the perpetrator. But this has very, very painful and serious consequences for when children get older and go into adulthood as well. It's an important time to learn social skills, to learn to feel good about yourself, and to help your self-esteem. So, how can you help your child develop social skills? One of the things is to teach and model healthy interactions, to pay attention to how you're getting along with the people in your life, to pay attention to if you're being positive, if you're reaching out to people, if you're being kind and supportive to people. You want to be positive with your children, and you want to praise them. And for kids with ADHD symptoms, you especially want to acknowledge and reinforce their behavior if they're paying attention, if you notice them managing their impulsivity, if you see them being calm, or you see them being relational. When we start reinforcing someone's positive behavior, the behavior that we perceive as being difficult often kind of just takes care of itself and goes away. You might want to start with young children having adult supervision while having play with one playmate. That way they can kind of learn to share, and they just gain practice in being friends with someone. As children get a little bit older, again, you want some adult supervision with multiple playmates so they can learn skills and build confidence. You want to encourage activities that involve peers, music, dance, jump rope, etc. So I am going to wrap this up now, but I too will be at the BVSD conference on November 6th, where we'll be talking more about how parents can support teens in relationship skills. Thank you.
So that's a good reminder that the conference is titled Late, Lost, and Unprepared, and it is Saturday, November 6th from 9 a.m. to 4 p.m. here at the BVSD Ed Center. And for more information about that conference, you can contact Anna Stewart at anna.stewart, Stewart, @bvsd.org. Our next panelist is Dr. Wyatt Fisher. He will talk a little bit about effective parenting strategies with ADHD children. Working with ADD, ADHD is Wyatt's passion. Having ADHD symptoms himself and a doctorate in clinical psychology, he is able to serve this population from both a personal and a clinical perspective. He strives to help people with ADD, ADHD make extraordinary growth by narrowing the gap between their potential and their performance. And as Dr. Wyatt is presenting his information to you, if you would please write your questions down if you're in the live audience, and if you're at home, please submit them to boulderpsychologicalservices.com. Wyatt.
Well, good evening. Tonight I'm going to talk about 10 different things that parents can do to improve the success with their children with ADHD. So number one, on average, everything that I have read speaks about how combination of treatment is best, meaning medication and behavioral therapy. Now, children with ADHD who are just on medication, typically that can decrease their hyperactivity and increase their attention span, but it doesn't teach them skills. And likewise, if they're just learning skills, it's going to be harder for them to remember it and replicate those skills without the stimulant helping them retain it when they're learning it and helping them remember to implement. So often combination is best. Number two, rewards and consequences are often helpful with children with ADHD. So they need something specific and concrete to strive towards, something to motivate them, to excite them to move forward, while at the same time they know what's going to happen if they don't. So you got to catch them on both sides. And with rewards, I'm sure a lot of parents know it's a moving target. So as children age and develop, what's going to motivate them and provide incentive is going to change as they change, as they get older. So having effective rewards that motivate them with effective consequences is really helpful. On the consequences side, a lot of research shows that it's not recommended to use any type of physical force, such as spankings or slapping or shoving. Anything like that is contraindicated for multiple reasons. One is it can be very scary for the child and can create a lot of animosity and anger towards the parent providing the physical force. And secondly, it models for the child that when someone is angry, it's okay to use physical force. So it's a poor modeling example. So it's ideal to develop alternative consequences such as timeout or privileges lost, overcorrection, which is where you have the child do the opposite behavior several times to reinforce the positive alternative. Number three, expectations in advance. So if you have a child with ADHD and you're going somewhere, or you have people coming to your house, it's very important to lay out with them in advance what you're expecting of them. So you don't want to say, Johnny, I expect you to be a good boy. Instead, you want to say, okay, Johnny, we're going to the grocery store, and I'm expecting you not to touch anything on the shelves, and I'm expecting you not to ask for anything until we get to the end of the store, and if you have good behavior, you get this reward. So make it very concrete and specific, and not nebulous and vague, so they know exactly what's expected of them, because one thing with ADHD is it's very hard shifting in task demand. So they need to get their head wrapped around what's about to happen and what's expected of them. That's really helpful. Number four, be a thermostat, not a thermometer. So parenting, if you have a child with ADHD, it's very easy to react to their strong emotions. So if they're upset, if they're frustrated, if they're yelling, it's very easy to just replicate right back what you see them doing and to escalate yourself. But often when that happens, things get worse and you're not modeling control for them. Because a lot of times for a child with ADHD, they feel out of control. So for the parent, it's very critical for the parent to model self-control and to be calm and to be firm, but also gentle, to strike that balance. You don't want to always be too gentle and never have any consequences, while at the same time, you don't want to be the opposite extreme and always be rigid and cold without having some firm, some loving kindness on the other side. So you got to balance the control and boundaries while also having the love and the nurturing in the relationship. Number five, unconditional love and empathy. So with a child with ADHD, they frequently get comments of, why are you doing that? You missed this again. You screwed up on this. Way to go. What are you going to amount to? They get a lot of negative feedback, whether from home or from teachers or from peers, which can quickly erode their self-esteem. So because of that, I think it's very important for parents to continually express the message that I love you right now. I don't necessarily love your behavior, but I always love you. No matter what, I always love you. And if possible, to empathize with your own struggles. So since ADHD is largely genetic, often parents can relate, with the struggles the child is having. So the more a parent can say, I know how hard it is to pay attention because I had a hard time paying attention, or I know how hard it is sitting still because I feel like I had ants in my pants and I couldn't sit still when I was your age. So the more you can empathize, the more it can help that child feel normal in a world where they often don't feel normal. 6, structure, structure, structure. The more you can provide structure, the better. Again, this relates back to difficulty in shifting in task demands. So the more ADHD children know what's going to happen, and then they know what's going to happen after that, then they know what the next thing is going to be, the better. So often, especially with children with the hyperactive impulsive side, they can do really well in school environments because it's very structured. So they have 15 minutes of this activity, then they transition over to this activity for 30 minutes, etc. And I hear a lot of parents say, that when my child gets home from school, they fall apart. They explode, they have terrible behavior, but at school they're doing okay. And often it's because they're going from a highly structured environment to a very low structured environment. So that's a real key piece to providing peace at home, is having a lot of structure. Number 7, similar to what Elizabeth focused on, is focus on strengths. So again, because it's so easy to hear the negatives and to be cut down and criticized so frequently, it's important to intentionally focus on the strengths. I know some parents who they make a list, a collage of all the strengths in their child, and they put it on their door. So when they go to that child's room, they see all those strengths before they see their child, just as a reminder of these are the positive qualities of my child, and I need to be focusing on those on a regular basis. Another idea is every night before you tuck your child into bed is to think of 3 things that you admired about them that day. Different choices they made, different ways they treated somebody, and sometimes you have to really search for that. But the more you can find that and build that into your routine with them on a daily basis, the better it's going to build their sense of self-esteem. 8 is quality time. So for most parents, life is busy, a lot going on. And for children with ADHD, it's easy for almost every interaction or majority of interactions to involve some type of correction or some type of lecture on what they need to be improving on. So it's great to provide quality time, carving out time with your son or daughter, even if it's 15 or 30 minutes a day or maybe one day a week, where you just do something enjoyable together. No talking about school, no talking about their misbehavior. It's just focusing on them and focusing on the relationship and cultivating just the love that you have for them as your child. Number 9 is limiting TV and computer. So with ADHD, it's very easy to get addicted to media because it's stimulating. And the brain behind the forehead, as Dr. Leland mentioned, is under-aroused. And so the brain's always looking for pleasure and what feels good in the moment. And so if you get connected to media, it's very stimulating, all the visual stimuli coming from the screen. And because of that, when you turn off that screen, it's even harder to pay attention without the same level of stimulation. So I recommend limiting computer and TV, all forms of media, to only 30 minutes a day, ideally, for children, and even adolescents, to really limit it, because again, that can compound and exacerbate the ADHD symptoms. Last is exercise, nutrition, and nature. So research shows, I'm sure a lot of people know, that exercise has many benefits, and especially for those with ADHD. One is that it decreases hyperactivity. It gets out the excess energy, so it calms the child down and the adult, and it improves concentration. So it gives the brain a bloodbath. So it's able to spike concentration for several hours afterwards. And so even having your children exercise before school, doing something with them is great, and after school, the more you get them active and going, the better. Nutrition is really important. So a diet full of lots of fruits and vegetables, lean proteins, and whole grains. I have read research studies showing that children who eat protein in the morning for breakfast have a greater attention span for several hours into school compared to children who do not. So protein for breakfast is important. Whole grains is important for attention, and fish oil is great for attention as well, for the supplement. And I always recommend with the people I work with to try everything natural first to see if that's enough for the boost in attention and the decrease in hyperactivity, and sometimes it is, and when it's not, then to add the layer of medication on top of that. Last is nature. There's a lot of research coming out showing the benefits and the power of being out in nature, in green space. So whether it's next to a river or a park or your front lawn, anywhere in green space, the more children and adults get out in nature, they're showing that it improves concentration, improves creativity, and decreases anxiety and stress and depression. So to get your kids moving, get healthy diets going, and get them outside. Thank you.
Thank you. And before we move on to our questions from the audience, I'd just like to put a quick commercial in that the next panel on Channel 22 is entitled Developing Self-Esteem in Your Child, and that will be Monday, December 6th from 7 to 8:30 p.m. And again, we'll follow the same format with a live audience and taking questions online as well. So the first question I have from our audience is kind of long, but it has a little bit to do with some of the things that Wyatt mentioned in terms of some of the things that are successful in school and what are some of the strategies that can help a student in school. And this is coming from somebody who works with students ages 5 to 6 at a school. She has many students with ADHD, ADD, and Asperger's. Do you think we should apply the same disciplinary actions for students as the rest of the classroom? And the example is, when class starts, we have a center time. Everyone sits on a rug and listens to the teacher. It probably takes about 30 minutes. The students with ADHD, ADD, or Asperger's can't sit even 2 minutes. She gives them squishy balls or something, but it doesn't help them. They run in the classroom, they start pushing their neighbors, or they play whatever they want. They're not afraid of anything. When they do whatever they want, the other students think that it's not fair. I would like to encourage harmony in the classroom, but it's very challenging. Would you please let me know what I should do for them? Wyatt, do you want to take a stab at that one?
Sure. I think that is a hard issue because from the student perspective, you want everything to feel fair and that the rules are the same. I think the ideal initial approach is to really think through rewards and consequences for sitting in that circle. It can be applicable to everybody, but you may need to apply it more frequently with the students with ADHD and Asperger's.
Okay. Jan, Elizabeth, Lee?
It might also help if the kids had some activities that they could do that don't require them to sit for a long period of time, since that really goes up against their challenges. And like Wyatt said, the idea of creating some positive incentive for them to sit still can be a lot more effective than negative. And keeping in mind that maybe for some of these kids that's beyond their ability, that they really can't do that. And so to make some modifications in the classroom might be a good idea as well.
Okay. And what about the piece in terms of addressing the inequity about how the other kids in the classroom feel when the kids who are different have a hard time sitting still, and it looks like they're getting to do what they want? What are some suggestions you would recommend for the adults in the classroom to help balance that as well? Lee?
This class sounds like it is a real challenge. Do you have any idea how many children are challenged in this way with executive function issues? How big the class is, or?
26 in the class, and 4 kids with
Ooh.
executive function issues.
Yeah, and is it one teacher trying to manage 26 kids with 4 children that are
One teacher.
stretching the boundaries? What's it?
One teacher and one helper.
Yeah. There's very interesting data about what can be seen in the prefrontal cortex, where during the ages of 0 to 6, there's a lot of synaptic architecture being laid down. And you can actually count the synapses that are being laid down and compare them from one population of kid to the next. And these kids who have executive function issues that are labeled this label of ADHD really cannot do so much of what's required of them in the setting, let's sit down and all be calm. They just cannot pull it off. And when there's one teacher and a helper trying to manage that many children, it is extremely tough. To sit up here and imagine that we have some way of advising what to do, I think is a real, it doesn't give appropriate credit to teachers that are put in this position. And there needs to be a lot more resources available for children who have this disorder. And I don't know at age 5 to 6 whether this gets discussed in your school, but there are facilities, and we can discuss that here. I mean, there are ways that these children should be getting addressed, whether they end up with the diagnosis or not. The diagnosis can be made that earlier and can be followed. And you hate to see children like this getting personalized identified, stigmatized because they really cannot perform what other kids do routinely. So the only thing I do is hats off to you and hope that there's some other measures that can be taken within your school to facilitate these children. That means being more active with them, off the floor, engaged, maybe a lot more one-on-one in certain situations, activities that are more appropriate with what children that have a lot of hyperactivity really need to do in order to succeed.
Okay. Elizabeth?
Well, I'm wondering if children can learn some kind of self-regulation, some kind of breathing exercises, some kind of, I've had kids tell me they learn in school to pretend like they're excited, mashing up paper and throwing it over their head. And maybe some of the kids who are having a harder time sitting still can take a more active role in getting up and showing kids and leading them in some demonstrations. Even doing the blackboard, taking the just giving them certain jobs that they can do so they can be active. Watering plants, cleaning out the fish tank. There may be some way to get rid of some of that anxiety, feel good about themselves, and still be involved in the classroom.
Okay, thank you. So our next question from the audience, it touches on a little bit of the things I think the panelists have touched on as well. Does ADHD tend to run in families?
Real quickly, 75% genetic loading for ADHD. And that means when you're dealing with a child who has these kind of executive function issues, it's very common that you're dealing with a parent that can identify very closely with the issues at hand. This has been studied very rigorously. There is not a single gene responsible for that genetic loading. It's a highly variable set of genes. And when you look at the prefrontal cortex, there's so many elements that are operating to perform executive function. The genetic loading can happen a lot of different directions.
Okay. Would anybody else like to respond?
The only comment for me is that's exactly what I've read as well. It's highly genetic, so typically one or both parents have it in some level. And then also, as far as permissive parenting, can compound it and make the ADHD symptoms worse, where there is no boundaries for their behavior at home and no structure or routine for them to follow.
Okay.
I like what Wyatt said about being a thermostat, not a thermometer, even though I had to think about it for a minute. And because it's very difficult if you have a child who's inattentive and hyperactive and you have had those qualities in yourself. I mean, it's one thing to be empathic, but it's another thing that when you get triggered easily, to be able to respond in a way that's in the best interest of the child and the entire family. So I think that what adults need to concentrate on is regulation of their own moods. And when you're looking at the way that you interrelate with other people or move through your own day, you need to be really honest with yourself about what kind of example are you setting. And I understand that that's a lot to ask of anybody. But I don't know any other way to help the child learn to calm down until they're in an environment of calmness.
And to piggyback off of that, I think one of the best ways to help parents be a thermostat is to make sure they're making time for self-care for themselves. Mm-hmm. You know, carving out time, even if it's 30 minutes for them every day, to do some soul care activities, whatever that is for them. I think it's critical, especially with a child with ADHD that can be so exhausting. You know, because the more their needs are met, the more likely they're going to be able to meet the need of the child.
Do you have anything you want to add, Jan?
I would just add that if a parent of an ADHD child has some of the symptomology, it's really a great opportunity for that parent to support their child in terms of letting them know, you know, I've been there, I know how that feels, sharing some of their own stories, maybe from when they were in school, and kind of normalizing it a little bit for their son or daughter.
Okay, great. Before we move on to the next question, I'm just going to make yet another plug for people at home to submit their questions via BoulderPsychologicalServices.com. and put in another quick commercial that on Monday, November 15th, Boulder Psychological Services Community Partners is offering a free workshop at the Meadows Library in Boulder entitled Mothers and Daughters, Exploring Relationship Through Empowerment, Voice, and Open-Heartedness. And this is for mothers and daughters, 6th grade through high school. So there's a series of questions that are somewhat related. And I'll start with the first one. When should an ADHD child have psychological or psychiatric reassessment?
Reassessment meaning they were assessed already.
I'm going to say yes because that's the way the
Okay.
question is asked.
All right. Usually every few years it can be helpful, but it's certainly not mandatory, especially because sometimes as kids get older, some of the challenges that they have become more clear through assessment. And so if you test a very young child, let's say a kindergarten age child, it's quite possible that when they're older, when they're in first or second grade, because of the amount of learning that they've done in school, because of their own psychological development, you might see issues emerge in the testing that might not have been apparent when they were younger. Years ago, schools regularly tested kids every 3 years. There's really no hard and fast rule. But certainly if you have concerns about your child, if they were assessed before, they continue to have issues and struggles, it's sometimes very helpful to get them reassessed so you have some current information. And this would also include not just testing the child, but also getting current information from the parents and from the teachers as well, which is really a very important component to a complete assessment.
Yeah, I would underline that, but say it from another direction. The term reassessment has got a formal quality to it, and I would agree with everything Jan says, but optimally, children are followed very rigorously because the disorder can cause so much dysfunction. And if it's truly an ADHD child who has a lot of executive functions, even though they're being successfully treated, there's so many elements to facilitating their success. So hopefully it's a process that just continues right down the line at every developmental step. We spend so much time thinking about this from a psychopathological perspective, and I want to make a point the other direction. Many of these kids have incredible talents and abilities, and though they may struggle with certain executive function issues, we can get so focused within our school systems about what they are not doing well is that we miss the chance to really evaluate what they do actually do well. I've seen a statistic about the MBA recently. 8% of the MBA has attention deficit disorder by history and currently deal with executive function issues. But it doesn't interfere, obviously, with their proficiency at being very physical, kinesthetic, and utilizing a lot of skills that just come so naturally to them. And so there are many people, there are other ways that this has been studied in various ways. What are the distinct advantages that someone with executive function issues may have in certain settings that don't exist in the typical verbal processing environment of a sit down and study type school situation?
I have two follow-up comments quickly. One with the re-diagnosis. I've worked with a lot of college students, and I know at the college level, disability services does require every 3 years to be retested. And research-wise, the frontal lobe of the brain doesn't fully develop until mid-20s, and 50% of children who have ADHD outgrow the symptoms to the degree that they're not diagnosed as an adult. So it's interesting tracking the diagnosis and reassessed as they get older as well to see how the brain development impacts the severity of the symptoms. To follow up with Leland's, I would agree with that as well. I think it is really important to also focus on the strengths. And some of the strengths that I really see on the ADHD side, the one is the ability to hyper-focus. You know, one of the hugest assets of ADHD is if you are interested in something and really passionate about it, you can do amazing work and really get engrossed in it where the outside world disappears. But it's accessing that hyper-focus ability that's the hard part. But once you get into that groove, it can be really phenomenal for people with ADHD. Second is creativity. You know, a lot of people with ADHD are really able to think outside the box, to see things from a different perspective, and their mind, especially with the hyperactive side, is often popping with new ideas, new insights, new strategies, new ways of thinking, so they can be very innovative as well with their thinking. And third is resilience. Because people with ADHD struggle in so many areas, I think it really cultivates a unique opportunity to develop resilience, because you have to continually strive and overcome obstacles that you're faced with.
Elizabeth, do you want to add anything?
No, thank you.
Okay. Listening to the panel, I'm starting to feel like I need to be tested. So the next question is there a way to determine if my son has ADHD without expensive testing?
Well, what's fairly common, for better or worse, is basing the diagnosis simply on the symptoms that Dr. Johnston went over earlier in our talk. The danger, though, is that there might be other things going on. And that can be really unfortunate in terms of sort of misdiagnosing or missing other factors that might be fueling the attentional problems. But it is a cost issue. Sometimes what we do is we test in a series. So we start off with certain tests and then see what the results are, and then look at possibly doing additional testing based on those results. It's more fragmented than giving a complete assessment. But psychological testing is expensive because it takes a very long time to administer the tests and an even longer time to analyze the results and integrate all that information, et cetera.
Lee, do you want to add to that?
Well, in one sense, a clinical interview, if not a too complicated condition, may be all that's necessary to make the diagnosis. Historically, looking at information from a variety of sources, and the decision can be made at that point as to whether you need further psychological testing to delineate things like learning disabilities or other concomitant features. So it doesn't necessarily require a huge expenditure of capital to get clarity about the diagnosis, unless there are a lot of complicating features.
Anybody else?
I worked with some children who were kind of on the borderline of the ADHD, and if they are motivated, and if you're consistent with teaching children about how to get organized, how to put their backpack together, how to get their homework done, then you might be able to help them learn certain skills that will prevent things from going downhill. Because if they learn it early, it also makes them feel better about themselves and their self-esteem, and all of that takes a more positive direction.
Okay. So I'm going to combine two of the questions from the audience because they're somewhat related. So the first one is, if my child is diagnosed with ADHD, what are my treatment options? And the second one is, when is it appropriate to consider medication for a child diagnosed with ADHD? Wyatt?
As far as treatment options for a child or adolescent, typically there's 3 different prongs to treatment. The one is some type of behavioral treatment, whether it's working with a coach or psychologist who's familiar with ADHD. Second would be working with the academic services or disability services through the school, through the 504 plan, getting some type of accommodation set up if they have a diagnosed, officially documented diagnosis of ADHD. And third would be some form of a stimulant, whether it's a medication route is the most common. Neurofeedback is an alternative, more natural alternative to medication. Some people like to try that, or through dietary or exercise options as well. But those tend to be the 3 main prongs: behavioral treatment, school assistance, and then some type of a medication of some type.
Okay. Anybody else like to add anything to that? Okay. So this is a more detailed question related to medication. My grandson, now age 12, this month, has had unsatisfactory results with medications. What medications have proven successful for children with ADHD? Should children with ADHD go off of meds at summer camp and have a vacation? He has tried Adderall, Vyvanse?
Vyvanse?
Yeah, and something I can't quite read. Begins with an S.
Strattera?
Yeah, Strattera, there we go. Anything better to try?
What was the question brought up here or by the computer?
By here.
Uh-huh. Can you hear a little bit more about the situation, what symptoms?
Very hyperactive, missed assignments, trouble focusing, trouble making friends in school, impulsivity, but distractibility, just a sweetheart, but really has reacted differently to different medications. Some of these said, well, I take them off the stimulant, Vyvanse, they have a vacation, but somebody else has been under treatment with the doctor down here, but it's just been inconsistent. We've had the last 2 summers, or a couple months each summer, and we just noticed a real struggle to find the right answer with the medication.
Okay, and before you answer, just in case it didn't get picked up by the microphone for the recording, so to summarize really quickly, he lives out of state and he's being treated currently with Strattera. He's a really sweet young man who is hyperactive. He has some impulsivity, and he spends the summers here with his grandparents, and it's been a real struggle to determine what medications would work best for him. And he has been diagnosed with ADHD.
Yeah. Well, I try to make a few comments that might address it. First of all, as was implied earlier, there's several prongs to treatment, and or not implied, but pointed out by Dr. Wyatt Fisher. In my experience, people do not come to see me until they've tried everything else. They don't want their children on medications, and it's a pretty much of a last resort kind of matter. The typical notion is that, and this may happen in pediatric offices, that the symptoms present and the first thing that happens is here's the medicine. But in a psychiatric office, most people don't want to see a psychiatrist. They only want to go see the psychiatrist if they have to. And it's very seldom that people go there except in the context of looking for a medication evaluation. So one of the very first things that I'm doing is trying to actually diagnose whether or not the given patient has attention deficit disorder or whether there are other complicating features. Because just the fact that someone presents with the symptoms does not dictate the diagnosis. These various other things that might be setting up the executive function issues that I mentioned earlier have to all be ruled out. And it's not very difficult to rule it out, but it's so pertinent because there can be things going on in a home, or there could have been something that happened traumatically, or there could be medications on board. A kid can be getting mistreated at school. There are many, many things that can get played into the executive function issues. But to answer your question the way you asked it, let's just assume that it is a diagnosis of exclusion, it is ADHD, there's nothing else contributing to the diagnosis. And your question is, well, would one of these medicines work better than another? Well, the medication process is all about side effects. That any of these medicines can be documented to have very equal efficacy. The ones that are approved by the FDA have very similar efficacy patterns. And what distinguishes whether someone can respond to one versus another is a trial and error process. And what tends to govern the process of moving from one medication to the other has a lot to do with side effects. Because many times you run into side effects before you can get to the therapeutic gain. So I wouldn't be able to answer this question just in the way it's been formulated without hearing a lot more data. But your answer to the question, is there other alternatives? Absolutely. You've really hit only two alternatives here. The Vyvanse and the Adderall are basically in the same family. They're just formulated a little differently about the way they're delivered. Strattera is in another class, but there are several other classes that have not even been considered, even though he's been on 3 medications. Now, I don't know if you want to hear the lecture about all the various medication classes, but I'll stop there.
Okay. Does anybody have anything they'd like to add to what Lee said?
Yes, I would add a couple of things. One, I really wonder about the diagnosis. In my limited clinical experience, when kids are really assessed thoroughly, and ADHD is clearly something that they have, usually the medication has a profound immediate effect, particularly in the classroom. And that's usually the key issue, is helping them to focus in school. The fact that he's been on different medications, it just makes me wonder, even though I understand that he was diagnosed with ADHD, but a lot of kids are misdiagnosed with ADHD. And then the other thing I wonder about is what we talked about earlier in terms of comorbidity or other things going on. So he may have, separate from the attention issue, some other issues that may be going on. And you know, for children and adolescents, just as an example, sometimes irritability is actually a symptom of depression, something that most of us don't know. And it's easy to kind of misinterpret that as a parent or a grandparent. And so I kind of wonder about that. I wonder about other issues maybe that aren't being addressed. And then, you know, the other factor that comes to mind, and Wyatt mentioned it earlier, is medication is one approach, but there's also some behavioral skill training, social skills groups, other things that might really support him in addition to the medication. You also raised another question about what's sometimes referred to as medication holidays, where children are taken off their medication during the summer, during school holidays, etc. And this can be beneficial because, you know, there are side effects to every medication, and certainly stimulant medication as well. It can affect growth, it can affect appetite, etc. It can affect sleep patterns. And so if the medication is specifically to assist in the classroom, you can make a pretty good case that it would be appropriate during the summer, during holidays, to take a child off of medication. However, I've also seen kids with some of that impulsivity factor that are accurately diagnosed with ADHD, and families choose to leave them on their medication because their ADHD symptoms, especially in terms of the impulsive behaviors, create problems at home too, not just in school. So that decision should be thoughtful, whether to keep the child on medication throughout the year or to consider those medication holidays.
Thank you. Our next question, how do you recommend homework is organized for a child with ADHD in 9th grade? Elizabeth, do you want to take a stab at this one?
How is it organized for someone in 9th grade?
How would you recommend organizing homework for someone in 9th grade?
I think that what you want to do is get a sense of the amount of homework there is to be done and try to break it down. Typically, for most people, doing the most difficult thing first is the best. Because when you get that behind you, you have a sense of freedom and you're moving forward. You feel like you've got something done and you can move closer to doing something that you would rather do. If parents can help kids organize their time, work for a certain period of time, maybe 20, 30 minutes, take a break. If you can exercise during that time, go for a walk, have some popcorn, come back and start again. And in the time that they are doing their homework, you know, you acknowledge them. Good job, I see you've been sitting there, you need some help. Whatever you can do to make it comfortable. I've also heard that sitting in a chair like we're sitting in right now is a very difficult thing to do if you have ADHD. And that for some kids, sitting on one of those exercise balls or having some ability to move physically is really helpful.
Okay. Wyatt?
Yeah, just to jump off of that, a couple things I would suggest. One is, you know, a lot of high schools, thankfully, are having the assignments listed online, so parents can go online to verify, to know, okay, yes, that is the assignments that this child has to do today. So I would say on average, you don't want to most likely trust the 9th grader with ADHD further than you can throw him or her as far as them telling you what they have to do that night. Just because it's so tempting to say, I don't have any homework, I promise. So I think the first step would be verifying what they have to do online and then setting up a routine that's consistent so it's predictable for them so they know when they get home at this time, no matter what, they transition over and it's time to study. And ideally, it's called the Premack principle, but where they have to do what they don't want to do before they're able to do what they want to do. So before they're able to do A, B, C, and D, whatever they're into, whatever their passions are, they can't access that until they've proven they've done their homework. And again, to hold them accountable, the parent needs to look at their homework and make sure they've done it like they said they have.
I would just add that, when you look at research regarding homework, the amazing truth is that for elementary age kids, there's no correlation between school achievement and homework. Zero. There's a slight correlation in middle school, but that's doing under an hour. And then in high school, no more than 2 hours. And so for children in general, we really, as a community, have to question the amount of homework that our kids are bringing home. It's very common for kids to be doing hours and hours of homework, and that's really tough for me to accept. It creates a lot of family conflict. It certainly is not providing that child with time to do some of the other important things, like having fun, playing with their friends, relaxing after school, especially for the ADHD child. The ADHD child struggles every day in school. And so Wyatt mentioned earlier a 504 plan. This is actually part of the American Disabilities Act, and it is our right under the law. It's the same law that requires ramps for wheelchairs. Any kind of mental or physical challenge, the person that has it has a right to have accommodations. And so, part of the testing that I do is including specifics about the 504 plan, if it's appropriate. And in the case of ADHD, it is appropriate. And one of the things that I always recommend is reducing the amount of homework to begin with, and to make it a little bit more manageable for the child. So that's something that could be considered as well.
I think there are a number of kids who would agree with reducing the amount of
Kids never disagree with me.
Yeah, they'd like that.
Adults?
So this is a two-part question, and I'll start with the first part. Can you revisit what's happening with the ADHD brain during TV or computer time?
You want to elaborate, Wyatt?
The main thing that I've been exposed to and have read in that area is that when a child is either on the computer or playing a video game or watching a TV program, all the visual stimuli on the screen is very captivating to the ADHD brain because the brain is under-aroused, so the brain is looking for arousal. So the media screen provides that arousal and can be very engaging, and that's why if not regulated, it can become addictive, for those with ADHD as well. And that's also why if that occurs for too long, it can make it that much more difficult to sustain concentration without the same level of stimulation.
Okay. So the second part of this is, with kids' busy lives, is it okay to eliminate screen time during the week and allow 2 to 3 hours on the weekend? And media time has been recommended. Limiting media time has been recommended for those with ADHD. What methods work to do that? And I just have to put a little plug in that I would think, I agree that limiting screen time is also related to other risk behaviors as well, in terms of decreasing them. And that's a talk in April that I believe we'll be having with this panel. But back to the ADHD piece, what methods would you recommend in terms of limiting screen time?
Let me make one comment about this in regard to media. It's a takeoff of what you were just saying concerning the way that kids relate to media. Unfortunately, media does not require multitasking. Most media is you're fed information. And kids that have attention deficit issues of one kind or another will get riveted to something that just is a passive vehicle of filling them up with one monochannel. That does not challenge the task of multitasking. It doesn't challenge any of the task of trying to figure out priorities. It doesn't really challenge the task of what we think of as modulating where you apply your attention, which is where the attention deficit disorder really has its life. So kids get very addicted to media. They love it. They love to be fed information and get very much into the pattern of utilizing media as a means by which they can avoid the challenges they face with this disorder. So it really has to be appreciated that when you're trying to break some of the habits that kids with this disorder have in regards to games and various other online activities and media saturation, it's a totally different process than just dealing with a child that has those issues and doesn't have attention deficit disorder. Kids love to be fed information that they're not challenged by the task of trying to prioritize information and move from one task to the other and try to multitask and coordinate, which is really the challenge of attention deficit and executive function disorders. So it's very much of a problem that kids with these disorders get very much addicted to media of various kinds. And the question is asked, well, how much, it's sort of implied that you can get away with a certain amount of media, and how much? Well, some of the kids who have very serious problems, you may have to ask the question, can they really participate in media saturation, because it can infringe so much of what they need to be doing about accomplishing tasks.
Okay, Elizabeth?
Yeah, I guess I understand what Dr. Johnson is saying. I'm not anti-media, but I understand the need to limit it. And what I want to comment on is that you can't, I don't think it's reasonable to expect a child who's been playing a lot of media to go cold turkey. If you're going through life, your parents are frustrated with you, your teachers are frustrated with you, your peers are rejecting you, and then you can go into this world that has some promise of being fair, and you can enter into this world where you feel like you have some power and that you have equals and that you have a chance. And in this world that you've maybe even created, named your own character, you can be distracted from the thoughts of what's happening during that day that's difficult for you. That's a pretty attractive thing. And so I don't think kids should have a lot of media either, but I think we need to be careful about weaning them off media and finding substitutions as they get off media, like nature, that I think is probably undervalued. Spending time outside, spending time with peers doing things that you're having fun with, identifying some kind of passion that you have other than media where you can excel, learn some social skills, and feel good about yourself. It's nice to feel competent.
Okay.
I would just add that, and we've had panels on media, it's a complicated subject, but I think part of the challenge is generational. I think for a lot of folks, a lot of parents and older folks, like myself, we're not used to all that media. Children today are much more caught up with social media than we ever were as children. And it's kind of part of their social fabric nowadays with Facebook and et cetera. I tried to set up a Facebook page, and then it asked me, what are you doing now? And totally freaked me out. That was the end of my Facebook career. But kids, it's another story. This is part of their life. This is a part of the way they interact with others. And so I think we have to be kind of careful and thoughtful. Media is a loaded word because that includes a lot of things: video games, television programs, the internet, social media, et cetera. So I think we want to do this in a really thoughtful way, not in a sort of one-size-fits-all kind of way. Wyatt talked about the Premack principle, the idea of using it as reward, the idea of using it to reinforce desirable behavior. I think kids should be empowered to have the discussion with their parents about media and how much is too much, and really to look to your child to provide some feedback and some buy-in in terms of whatever your strategy may be in terms of reducing media. And we also want to make sure that kids are actually doing healthy things. They're meeting their responsibilities at home and in school. They're having good socialization experiences. I worked with a young man a few years ago. All he did was be on TV, World of Warcraft. I said, do you have any friends? He said, I have a lot of friends all over the world. But they were all kind of virtual friends. He didn't have any friends in his neighborhood. And that's too much. So it's a balancing act. And I think that's what we want to do. We want to take it family by family, each unique child, empower them, and try some experiments at home, reducing media time, but increasing healthy activities, and work with our child, do it together with our children.
Great. Thanks, Jan. Now I understand why you haven't Facebooked me yet. So we have a question. Woohoo! We have a question from a viewer at home. I'm going to ask this first question, although I'm not sure how comfortable the panel feels in answering it. What middle school in the Boulder Valley School District system would you recommend for a child with ADHD who struggles academically but is very creative and artistic? And if you don't have enough knowledge about the schools to answer that, I can go on to the next one.
Well, we're in the BVSD boardroom, so I'm a little afraid to answer that question. I can tell you just from my own sort of subjective, limited experience of working with kids from different schools. First of all, I always find it entertaining. I always ask kids what school they go to and whether they like it. I can tell you that all kids love and hate every school in the district, for better or worse. I don't know what that means exactly, except that it's not so much a black and white thing. One school's good, another school's bad. I've heard wonderful things about Platt Choice, which is a part of the Platt Middle School. I've worked with a lot of kids that had significant learning problems. One girl in particular that had severe learning problems, and her one positive moment in her schooling career was when she was at Platt Choice. So I would put that out there.
Okay. This is, oh, Lee, sorry.
I wanted to say one thing about that issue, is if we would be able to know which school would apply. It speaks to the incredible variability of the way these symptoms present. And the more we've learned about the disorder, the more we understand how complex the prefrontal cortex is. And so when ADHD is a very simplistic labeling system. In fact, it was created in 1994, in the years prior to 1994. Just like right now, we're trying to create the labeling system for 2012, when the next DSM will come out, the next Diagnostic Statistic Manual. And it's always behind the research. The Statistic Manual is a way of trying to coordinate groupings of kids and adults so that you can perform some double-blind research prospectively. It's utilized for many other purposes, but it sort of puts the diagnostic criteria into these narrow elements that I think any given parent would be wise to find out what school meets their own particular child's needs, because it varies a great deal.
Okay. The second part of that question was her daughter takes a Vyvanse and Intuitive and wanted to know what you thought of that combination. And she's also very sensitive to stimulants, and if there was another option for her.
This is someone
Online.
Online, and they've had a good response to Vyvanse and Intuitive.
Didn't say.
Okay. There are attempts to combine medicines, and it typically doesn't happen until you've tried a variety of monotherapies, meaning one medicine. When you begin to combine medicines, you've already started down a pathway that can be very fruitful in some situations. That particular combination is a combination of a long-acting medicine that's a stimulant, Vyvanse, and it's a combination of something that hits the alpha-2 receptor. The Intuitive is just recently out as an extended release formulation of something that hits an alpha-2 receptor. It's a different receptor mechanism, and it sometimes can be a very successful combination. They're not having success with it is what's implied. Is that correct? By the time somebody is into combination therapies, they've typically tried a number of other monotherapies. I wouldn't want to make a guess on the basis of that question. What would be a good alternative?
And I just wanted to do a quick check-in. We have about 5 minutes left, and I don't think we're going to get to every question that we have, but there's one question we got online that I would like for the panel to address. It's from a teen with ADHD. He or she says it often takes a long time to pick up on basic concepts and principles. As a result, my parents are often quite frustrated with me for repeating behaviors they don't like. How can I explain to them how I'm having difficulty, and what can I do to try and pick up these concepts?
I think that one of the things you can start with is actually using I statements with your parents and saying, I understand I'm frustrating you, and I'm doing the best I can, and ask your parents for help. I mean, ask your parents for help in catching you being good. Ask them to point out to you when you do things well. A lot of times, it's very easy to criticize behavior we don't want to see, and yet what we know scientifically is that the best shaper of future behavior is positive reinforcement. So if this child can get their parents to model behavior for them, to work with them even on what it is they're doing, and being very specific with what it is they want them to see, because like Wyatt said earlier, it's if you're good, you can get this. Well, if you're good is too vague. So it's if you can give me certain tasks and certain goals, and I can finish those goals, what then might my reward be? Because sometimes all that gets very unclear. Good, bad, like, dislike. It needs to be clear and concise.
I just want to compliment this young man or woman for even asking that question. It seems very rare for a teenager to want to improve their relationship with their parents and asking for help on how to do that. So I just want to compliment him or her, if they're listening right now, for even asking that question. And I would suggest, it sounds like they're diagnosed. If the parents are open to it, one option would be family therapy, going into a psychologist or someone who's familiar with ADHD to explain to the parents. Because a lot of parents, I think, misinterpret the behaviors of a teenager or child with ADHD and see it as, they're just being disrespectful to me, or they're just doing this out of spite, when in actuality, sometimes that may be the case, but in other instances, it's the symptoms that are, creating those behaviors, and being able to tease out what's creating those behaviors, I think, is really important for parents to have an appropriate reaction. So family therapy is an option if the parents are open to that. Books or websites such as chad.org or add.org for the parents to become more educated on what is normal and what's considered ADHD behavior for a teenager.
Okay.
I would just add that one suggestion I would have, in addition to the great feedback from the panel for this teenager, is to wait for a positive moment. Usually we have these discussions at the worst possible time. Wait for a positive moment with your parents when things are going well, and really just in a very assertive but diplomatic way, let them know how you feel. Share your feelings with them. And of course, you could always have them watch this panel, because this is a great opportunity for Segue Plug. These panels are archived on bvsd.org. They can be watched at any time. Tell your parents that you want to watch an educational show with them, sit them down, and they'll get our responses directly.
I think that this is a perfect opportunity to add the remaining commercials we have, again, for this Saturday, November 6th, from 9 a.m. to 4 p.m., Late, Lost, and Unprepared, the one-day conference on ADHD here at the BVSD Ed Center, 6500 Arapahoe. Again, contact Anna Stewart at anna.stewart, STEWART, at bvsd.org, or you can call her at 720-561-5918. On Monday, November 15th, BPS Community Partners will be offering the free workshop at the Meadows Library entitled Mothers and Daughters, Exploring Relationship Through Empowerment, Voice, and Open-Heartedness for Mothers and Daughters, 6th grade through high school. And the next Channel 22 BPS panel is Monday, December 6th, from 7 to 8:30 p.m., again here in the BVSD boardroom. And the title of that panel is Developing Self-Esteem in Your Child. I would like to thank our panelists, Dr. Leland Johnson, Elizabeth Matthews, Dr. Wyatt Fisher, and Dr. Jan Hittleman, for providing such great information tonight. I would also like to thank our audience here and at home for providing such great questions for the panelists, as well as our partners and our sponsors. You can find out more about all of the BPS community events, as well as to view previously aired programs, by visiting the BVSD website at bvsd.org or boulderpsychologicalservices.com. Thank you, and see you next time.
You are like the moderator.
1, 2, 3, 4. Hey, I'm making my own way, but I stumble and I falter every day. But I love my baby now. Well, I love my baby, I'm still learning how. Hey, 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 I'm okay. Stay with me. We'll beat this, can't you see? And wait a while, winter time.